Hello everyone, we're at Eha25. My name is Doris Hansen. I'm from H. Lee Moffitt Cancer Center and Research Institute from Tampa, Florida in the USA. Today I had the opportunity and pleasure to participate in a symposia discussing relapsed refractory myeloma, unmet need, and revolutionizing CAR T-cell therapy. So certainly we have multiple CAR T-cell products that are approved. They are moving earlier in lines of therapy, which is very exciting. But certainly we have areas of unmet needs that we can focus on. We've had some new data from CARTITUDE-4 showing with cilta-cel we can perhaps overcome some poor risk features such as high-risk cytogenetics, deletion 17p, 414, 1416, and the combination thereof. And we saw significant improvement with cilta-cel by lines of therapy as well. Importantly, at the conference, we've also seen some long-term data from CARTITUDE-1 with 5-year follow-up, where of 97 patients infused in the study, a third of them, or 33%, were essentially at 5 years without evidence of progression and alive and treatment-free. The magnitude of these results is truly transformative and impressive. We're at a time period where we are perhaps discussing a potential functional cure, curative potential of CAR T-cell therapies for multiple myeloma and for our patients. Truly very exciting. Other data I'm excited about the conference, there's going to be an update on anito-cel or Imagine-1 with slightly longer follow-up. And what we have seen so far is that responses look quite good. We are seeing deepening of responses, particularly complete response or better, and with about a 12-month follow-up, no evidence of neurologic toxicities such as Parkinsonism, cranial nerve palsies, or IAC colitis, which is truly impressive. And there's going to also be some data on, how do we predict, for Mayo Clinic, how do we predict which patients might develop some of these toxicities, and what might predispose them to these toxicities, such as, for example, higher disease burden and absolute lymphocyte count over 3,000, as well as a kind of refractory and prolonged inflammatory profile. Last but not least, we did have some data on cytopenias, infections, and immune reconstitution following CAR T-cell therapy. This is from the Myeloma Immunotherapy Consortium led by my colleague, Dr. Denai Dima, as well as myself, where we looked at cytopenias, immune reconstitution in over 100 patients treated with cilta-cel. And really what we're seeing is that severe cytopenias, grade 3 or higher, occurred in 40% of patients. By day 90 to 6 months after treatment, that number reduced to 13 and 14%. From an infectious standpoint, we saw that generally within the first 30 days, most common infections were bacterial and viral, and beyond that, viral, such as COVID-19, RSV, rhinovirus, etc. Going back to the cytopenia, the patients at higher risk are those with a high CAR hematotox, high tumor burden, EMD, etc. We did see utilization of 10% stem cell boost, TPO agonists, as well as 50% IVIG use. And I think what makes this data important is the fact that infection is the leading cause of non-relapse mortality. And also we are moving CAR T-cell therapies earlier in lines of treatment, which means it is paramount that we optimize supportive care protocol for our patients to help improve their outcomes, not only from an efficacy, but also from a safety standpoint. Thank you very much for having me.